So thank you and good morning for inviting me today. It is a great pleasure to see you here. And personally, I met this association so many years ago, and I can see that you are so dedicated to the patients affected by Crigler-Najjar syndrome. So I would like to congratulate for your competence and for all you do for the patients. It's not that easy to talk to you because personally, I think, it is easier when we are invited at conferences where we know exactly the target we want to achieve. But in this case, it is more difficult because among the audience today, we have people who know all practical aspects of the disease because unfortunately they suffer from it, and we also have people knowing more about the scientific features and aspects of the disease. So I was asked to give quite a technical presentation about, in particular, the risk of nuclear jaundice in non-infant patients and also gallbladder calculus. So you have to know that I found the pictures of these two persons who described first the Crigler-Najjar disease, and I've never found the pictures before, and these are the two people who in 1953 described a mysterious illness that caused jaundice and severe neurological damage. Of course, if we want to talk about jaundice and kernicterus, we have to start with the metabolism of bilirubin. I will try to make it as easy as possible. So first of all, bilirubin is produced starting from heme, and which is a molecule with iron, which is mostly found in red blood cells. And so most of bilirubin is produced by breaking down of red blood cells, or also due to hemolysis extravascular, or also in case of comorbidity, so other diseases associated with it causing jaundice, for example, or also some red cells are broken down when they are precursors, and they can release bilirubin. And this is 80%, whereas 20% comes from other molecules, for example, cytochromes and other enzyme systems, which are very important in human metabolism. In this slide, you can see the pathway leading to the production of bilirubin. We have, say, the iron in the center of the molecule. Iron is oxidized, and it becomes biliverdin, which in turn is broken down to bilirubin. So you can see here the extended formula of bilirubin, which is the unconjugated one. So the one that we know as indirect bilirubin, which is found in blood when we do blood samples and tests. And so you can see here the red blood cell, the indirect bilirubin is released into the blood, and it is found in the liver. Then in the liver, it must be conjugated in order to become water soluble. And so we will see that it becomes water soluble, and it is excreted in the bile, and then it enters the bowel. So it is eliminated through the feces, but part of it is not conjugated, and so there is a sort of hepatic circulation. So part of bilirubin is going back to the liver and the bowels. So this is a sort of a loop, a circuit, and if we are able to break it down through drugs, basically we can reduce the level of bilirubin in the blood because we can reduce the amount of bilirubin circulating. However, in the type 1 syndrome, CN syndrome, this has a poor impact. Normally, when we have unconjugated bilirubin, bilirubin can increase due to excessive production, so red blood cells are broken down, or we have captation, an impaired captation, so it is captured basically, or, and this is what we have in this CN syndrome, we have an impaired conjugation, so bilirubin is not conjugated properly. There are also other forms of jaundice which are caused by direct bilirubin. And these diseases, for example, have an excretion problem. So we have conjugated bilirubin, but the problem is getting rid of it. And so these are the other types of diseases. Whereas the Crigler-Najjar syndrome concerns the enzyme which basically create the conjugated bilirubin. So the neurological damage is caused by the fact that indirect bilirubin is not water soluble. So in brain, for example, we have lots of lipids. So if we have a high amount of unconjugated bilirubin in the blood, then this could be a risk of damage for the brain. So why is not water soluble, first of all? Well, first of all, this is what happens when we have a high level of bilirubin in the blood. So you can see that basically the basal ganglia are affected in the brain. You can see this yellow area in the brain. So indirect bilirubin is not water soluble, and this is the main risk for brain. However, once again, this is the formula of the molecule for bilirubin. However, there are hydrogen groups in the bilirubin which would make it water soluble, but these hydrogen groups create bridges. So you can see that hydrogen creates bridges so that in the end the molecule in a way hides this group, this methyl group, which is very important. And so theoretically the groups which would make it water soluble are not available because they link together. So these links are created and the molecule becomes it's not water soluble. So if we look at the molecule and we consider the shape, so in the space, you can see that basically it folds on itself, and so the nucleus is hidden and the hydrogen links are not available, and they would be important in order to make it water soluble. And this is important because we can better understand what happens when we have conjugated bilirubin. So when it comes to indirect bilirubin conjugation, so first of all, you can see here the links I mentioned before, but when bilirubin reaches hepatocytes for conjugation, the enzyme is conjugating the acid to these two groups. So these two groups are not available to link with the other hydrogens, And so the hydrogens are available for links to make it water solubles. And so we can have the possibility to eliminate it. So when it is bound in the hepatocyte, it becomes water soluble and can be eliminated in the bile or in the urine. Considering the molecule of bilirubin, well, why phototherapy is useful, first of all? Well, this is the molecule we have seen before with the bonds created beforehand. So phototherapy breaks the hydrogen bonds temporarily. And so in the end, the final result is that the carbon is displaced. And so what happens is a chemical transformation which displaces carbon, and so the bonds created are broken down, and temporarily the molecule becomes water soluble and so can be eliminated. So let's have a look at how bilirubin is conjugated and transported. This is a video clip I found from a scholar Mr. Chowdhury, who has been studied a lot on jaundice, and in particular, I wanted to look at the risks of kernicterus linked or associated with bilirubin metabolism. So this is a liver cell. We have sinusoidal surface here. And here we have the canalicular surface where bilirubin goes in order to be eliminated in the bile. And cells are bound by the tight junctions. And this is the blood vessel where blood flows, of course. And in between the hepatocytes and the blood vessel, we have the endothelium, and we have a fenestrated endothelium, so basically some cells can go through them. So bilirubin is bound to albumin, and this is important because when it is conjugating with albumin, it's not toxic, whereas if bilirubin is not associated, is not bound to albumin, then it may damage the brain. And so, as we said, bilirubin usually has a bond with albumin. So in this case, it is water soluble. It circulates, so there is no build-up in the tissues. There is no excretion through the urines, but this bond, which prevents, in a way, the risk of jaundice, can be broken by drugs. So drugs having affinity for albumin. So basically, the bond is broken. Bilirubin is alone, so there is no bond with albumin, and then the risk arises here for damage. So when bilirubin reaches the liver in a normal condition, dissociates from albumin and enters the liver cells. And so the hepatic cells have to capture it. However, it is a two-way situation, so it can also go out, but there is a system binding it. However, when bilirubin enters hepatocytes, well, this is something which is reduced in newborn babies, so this is why newborn babies are more exposed to the risk of yperbilirubinemia. You know that normally there is a physiological jaundice in newborn babies. Why is that? Because the liver is immature and there is a poor ability to make indirect bilirubin into the hepatic cells. There is, however, a system which maintains bilirubin inside the cells, and they are the so-called ligandins. These are molecules that retain or maintain bilirubin in the liver. However, this is not enough because bilirubin is not water-soluble yet, so it is not possible to eliminate it. And the system which eliminates bilirubin, which is what is missing in the CN disease, is the UGT1A1, which transforms indirect bilirubin into direct bilirubin, thanks to a bond with the glucuronic acid. So the direct bilirubin in this case can be eliminated. So bilirubin is not toxic any longer and can be excreted in the bile through the MRP2, which is an enzyme system. So this is the part of the biliary ducts that allows for the elimination of the bilirubin into the bowel. So I hope I explained the most important steps of bilirubin metabolism. So let's now focus on the risks of jaundice and also neurological damage. So the risk is an increased. Right, so if bilirubin in the blood increases, this may entail a risk. For example, it may happen that a person affected by a disease such as Crigler-Najjar syndrome may have another disease which could cause an increase of bilirubin, or even infections could cause the breakage of red blood cells. And so all these would increase bilirubin, or even inefficient phototherapy could cause an increased level of bilirubin and, of course, kernicterus. Or if bilirubin is dissociated from albumin, for example, there are some drugs which could cause this. So if bilirubin is not bound to albumin, so this may be dangerous. So we may also have brain damage, even if the level is reduced, it's not so high, but it is not associated with albumin. There is also another risk caused by the inhibition of ligandins. However, the most common condition that we find also in a Crigler-Najjar syndrome is the associated with the UGT1A1 activity, which is impaired, or if other diseases are present, so if there are problems in terms of excretions, then we may have a risk of icterus, of jaundice, or we may also have sort of mechanical risk. So if stones are present, for example, in the bile ducts, then of course bilirubin increases and the risk for the patient increases as well. As I said, there are some drugs which displace in a way the bond with albumin, and also other drugs that in a way interacts with the UGT1A1 activity. So for example, if we consider the Crigler-Najjar syndrome animal model, so we have, first of all, the animals with no disease, for example, a rat, so untreated. The activity of the UGT1A1 is 100%. But if we use, for example, phenobarbital, the enzyme conjugating bilirubin increases the activity. And the same applies to other drugs used, for example, to reduce cholesterol. for example, all these drugs increase the metabolism of the UGT1A1, and also some antibiotics, for example, can increase the activity of the enzyme, or the hormones, on the contrary, for the thyroid, for example, they decrease the activity of the UGT1A1. Unfortunately, all this applies to the one having a residual activity of the UGT1A1, but in the CN disease, there is no activity, so the drugs have no impact on that. Whereas in the type 2 CND, we do have a residual activity, so the indirect bilirubin level can be decreased by these drugs. Now, when it comes to stones, well, it is really difficult to have scientific evidence, in particular for type 1 Crigler-Najjar syndrome, because when it comes to adults or non-infant patients, unfortunately, we have just a few of them in the world. So, type 1 CND patients who reach 10, 11 years, well, we don't have so many of them, unfortunately, because, well, they have to undergo liver transplantation. So talking about adult patients, well, it's almost impossible. We have you in the world, but not so many people who did not undergo liver transplantation. So, however, this is a paper I found in literature. I think it is the only one I found which provides data about long-term follow-up for patients affected by CND. Well, first of all, the incidence of calculosis in the CND is unknown because we don't have so many cases. You know that calculosis is very common also in a general population, in standard population. But, well, is calculosis a risk factor for neurological damage? Well, it is difficult to say, but of course, if we have an obstruction, well, there is a risk, that's for sure. And secondly, should we treat it more aggressively? So in case of stones in the gallbladder, should we be more aggressive if compared when treating a patient with no other diseases? Once again, we only have very few data about this, but in this paper, we found that calculosis is very common over time. So 20 patients were enrolled in this study, and almost all of them basically had stones, and some of them, or most of them, had to undergo cholecystectomy, and unfortunately, the UDCA, which is used in this disease, did not prevent the stones, the calculosis, because even though they used it, they had stones, so it was not prevented by this. Now, preventing kernicterus. In this case, I would like to present you some data from a study in which 20 patients were enrolled. So a group selected in Stanford. So they wanted to maintain the bilirubin albumin ratio in serum below 0.5 in newborn babies and below 0.7 in older age. So this means that we do not look at bilirubin level only, but we prefer to focus on the bilirubin-albumin bond, and we want to maintain it at a specific ratio. And of course, avoiding drugs that affect the bilirubin-albumin bond, because in this case, the risk of kernicterus would be higher. And also, early treatment of bilirubin peaks caused by other concurrent diseases. And this is the formula used to calculate the bilirubin-albumin ratio. So it's quite technical. However, there is a specific formula using the same unit of measurement to have the same values. So this chart, however, is important because it answers our question about brain damage, which increases over time, so as the age of the patient increases. Unfortunately, the answer is yes, because in this case, we have the bilirubin-albumin ratio in years. So this ratio, which is very important and can affect brain, so at 5 years, it's 0.3, but when you are 18 years old, then you see how much the risk has increased. And when we are 20 years of age, we reach the risk threshold, the risk level. So you all know the risks, but as age increases, unfortunately, the risk increases slightly. So not so increases, so further measures are needed. So this group also considers the patients having a neurological damage and the ones who did not have it. And so you can see in the ones who had it, you see the level. So the recommended ratio is 0.7. So the ones who were affected by kernicterus had a much higher level, much higher ratio bilirubin-albumin, whereas the ones who had a high level of bilirubin had no residual damage.
This slide is technical. What do we do when we have an emergency in terms of high bilirubin? Well, quite obviously, we have to know which systems we have to use to quickly lower bilirubin when, despite phototherapy and all of the other therapies, bilirubin goes up. And so there are initial symptoms of brain involvement. So I'm not going to go through the slide, but we have to intensify phototherapy, make it as effective as possible. And then, since the bond with albumin is so important, we have to administer albumin. By so doing, the ratio we were talking about goes down. In some cases, it's necessary to do plasmapheresis, which is some sort of dialysis, but much simpler to do in technical terms, in which plasma is taken away and it is replaced with new plasma. Since bilirubin is mostly bound to the albumin in the plasma, if you take the plasma away, bilirubin goes down quite a lot as to that. And then we have to avoid drugs that change this ratio between albumin and bilirubin, and then, for example, oral calcium carbonate can be given, and then it is important to keep a balance with normal glycemia, and not to administer parenteral nutrition with proteins and lipids which can interfere with bilirubin values. As I said, we have very few studies, and most especially in many centers, the Crigler-Najjar patients have early transplantation. Today, we don't talk about the indication. I mean, it's not easy to decide when a patient can continue with therapy, and when instead a patient is a high risk, and as a result of that, he or she should have transplantation. This can happen at any age, because in certain conditions, in point of fact, also kids, little kids cannot maintain adequate bilirubin levels that keep them safe. So in these studies, for example, the study I talked about shows that the average age of transplantation is 16, quite high. In other centers, the age was 5, 6 years or 9 years. I'd like to conclude by showing which are the drugs which are not advised and which are at risk. Probably you already know this. Anyway, these are the drugs which are at risk for shifting the ratio between albumin and bilirubin. For example, this is class 2. Instead, class 1 are the probably safe drugs. Instead, the class 2 ones are viewed as not being safe as drugs. For example, aspirin, which is viewed as being not safe because it changes this ratio. Instead, ibuprofen is okay, and other anti-inflammatory drugs are okay as well. Then there are other drugs like antibiotics. I mean, not the most common ones, but it's important to know that some antibiotics, the ones listed here, can interfere with this bond. An antibiotic which is very much used is ceftriaxone, which is not advised in this condition. And then there are also other drugs, like some tetracyclines, and most especially the so-called sulfamidic drugs. Sulfametosazole, sulfasalazine. And then there are other drugs like iodate agents. When you have enhancement imaging tests, they change the ratio. And then some diuretics are at risk, but they're not very widespread, the ones in this list. And then there are also other drugs which are not very widely used, like anesthetics. Thank you. Okay. Since we have Dr. D'Antiga here with us, so we can ask some questions based upon his presentation. Any questions? Beatrice? I have a curiosity. Thank you. As I was saying, I have a curiosity. When you talked about the various drugs that somehow activate UGT1A1, we only knew phenobarbital, but you mentioned rifampicin that could be used as an antibiotic. Is that right? It is an antibiotic. Usually we take amoxicillin. So since I'm not a doctor, I was wondering, could it make sense to take rifampicin and hope that it also does something more when we take it? No. The answer is no, unfortunately. Rifampicin in general is an enzymatic inductor. We also use it for other jaundices. For itching, it works at best because in general it activates the hepatocyte enzymes. It was conceived as an antibiotic, but it is no longer used as an antibiotic, essentially. It's not a good alternative to amoxicillin, which is certainly the best antibiotic for most conditions. So it wouldn't be appropriate to replace this drug in terms of antimicrobial treatment. And then in the type 1 Crigler-Najjar syndrome, there is nothing to be induced. So rifampicin doesn't increase the conjugation. No hands up? Good afternoon. I have a question. I'm her mum. She's type 1. But it's not really true that the drugs you mentioned are not absolutely useful. I mean, back then, as a little kid, she had the phenobarbital test and she had no result. But for example, cholesterol works on her. Paxabel works on her. She's type 1. So it's true, we know that there are many overtones of this yellow in point of fact. But I can tell you this much, based upon my personal experience, it's not, as you said, also type 1, luckily, can benefit from some drugs. Yes, I can tell you a couple of things. First off, some drugs act on intestinal recaptation. Those that act on the bowels can have some effect because they reduce the little amount of bilirubin that is recovered from the bowels. For example, laxatives and calcium reduce reabsorption. So they don't act on the liver, but they reduce the intestinal reabsorption. And then you have to think that from the genetic point of view, unfortunately, we classify diseases. We put them in boxes. But type 1 and type 2, Crigler-Najjar, are not into segregated boxes. There is no precise cutoff. Every genetic disease, in point of fact, is expressed in a different manner because it's not just a matter of genes. I mean, there are many other factors around the gene. So it's never like this. I mean, for our convenience, based upon the levels of bilirubin, we define diseases, but it's also true that within the same disease, we have different patients, and the enzymatic activity is not zero in all patients. And this applies to all diseases, and well, it applies to the Crigler-Najjar syndrome as well. Katia? Good afternoon. Calcium carbonate, is it always an enzymatic inducer? No, it has an effect on the intestine. So type 1 could have some benefits from it. Yes, it could have some benefits, meaning that the intestinal recaptation could be reduced. Is it a drug? Like barbiturates? No, it's mineral salts. So this is evidence that you can use it without complications. Yes, I confirm that. If I may, I'd like to specify one thing with respect to calcium carbonate. The effectiveness is connected to a different mechanism, and our Dutch colleagues who've carried on experimentation with this substance, which was a mix of calcium phosphate and calcium carbonate, have shown a decrease in the effectiveness of 10-15%, and almost all Dutch patients use it. And this percentage of effectiveness is more or less the same that many of you have by using or not using UDCA and polyethylene glycane and Paediapax or Paxabel. These are the measures. Quite obviously, these are ancillary drugs. In any case, they partially decrease bilirubin. They cannot replace, but only add to what you normally do. I was wondering if calcium carbonate replacing Paxabel, which is a drug, can it work? I mean, the latter is a drug, but the advantage is that the excretion is in the feces. There's no chemical interaction with the body. It's not absorbed and then metabolized. It stays there, retains water in the feces and goes away with the feces. So from the point of view of the management, it's very simple, I would say. Lorenzo, do you agree with me? Yes, absolutely. And also Macrodol. which is present in these drugs, well, we use them a lot. It's a laxative. It's the one that we use for all kids, for all patients. It's an inert molecule. I always tell mums, all that goes in from the mouth goes away, goes out from the bowels. And also calcium, as Mr. Ronchi said, is one of the drugs which in the intestine can have a slight effectiveness and have no side effects. Any other questions? There's a hand up over there. Hi, my name is Leo. I come from the province of Avellino. Here's Salvatore, 27, type 1. I have a question on plasmapheresis because Professor Iori at Naples, as bilirubin goes up, they often call us for plasmapheresis. It's very much used to lower bilirubin. We have noticed that we do plasmapheresis, and after 2-3 days we go back to the same values. So I'm wondering, these up and down of bilirubin, I mean, how shall I say? We've tried not to do plasmapheresis once, and the values have remained unaltered. So should we do it, or often, or once in a while? What do you think about that? I think that I'm in agreement with most of the persons who deal with this disease, that plasmapheresis is an emergency treatment only in this condition. It's not a standard treatment. Bilirubin can be produced in large amounts very quickly, so plasmapheresis lowers bilirubin for a short period of time only. So, for sure, it's not something you have to use in the long term. It's something you have to use if the bilirubin levels are quite high, and also taking account of this ratio between albumin and bilirubin. However, I don't know. I know the professor you mentioned. Maybe. Okay, Professor Iorio. I know him. He's a good hepatologist. Maybe he's concerned because bilirubin stays quite high over time. Well, in that case, plasmapheresis could be done. But plasmapheresis is not the solution, the ultimate solution. But maybe there are other measures to think of so as to reduce risks. But I would say that plasmapheresis should only be an emergency treatment, not a standard one. We have a gift for Dr. Lorenzo D'Antiga.